The goals of neurological examination. The first one, to determine whether in fact any neurological dysfunction exists, even the patient is unconscious or not even conscious, and to identify which component of neurological system affected, that is either motor or sensory or cranial nerves, and even to locate the precise site of the problem, where exactly the problem, and we can generate the possible list of etiologies, and even we can document the or screen of baseline function for those who are otherwise healthy. And the indications mainly to rule out meningitis, head injury, brain tumors, a cerebrovascular accident or recurrent episodes of unconsciousness, tetanus, any history of epilepsy, any neurological disorders or high-grade fever, coma or progressive muscle weakness. What are the equipments needed for neurological examination? First one, sheet to cover the patient, and the gloves to prevent cross-infection, and the reflex hammer to elicit the reflex, and the tongue depressor to examine the pharynx, and the tuning fork to assess auditory nerve, and the Snellen chart to assess the visual acuity, and the penlight or either otoscope to through light in cavities, mainly to visualize the ear and nose, and cotton swab to white secretions, and even BP apparatus and stethoscope to assess the vital signs and do the auscultation, and the kidney tray to collect the waste, and test tubes to have hot and cold water to assess the sensation, and watch to measure time duration, and common pin or needle to elicit the reflex, and fruit, or even we can use shampoo or coffee powder and whatever it may be in order to test the sense of smell, and the pen or coin to elicit the reflex. What are the steps of assessment? So first one is mental status examination, second cranial nerve examination, and motor function assessment, sensory function assessment, assessment of cerebellar function, and assessment of reflexes. And the level of consciousness, and the note if the patient is awake or alert, and consciousness is an alert cognitive state in which the person is aware of self and environment. So if not described, what level of stimulus is needed to arouse and keep patient awake, we can open eyes to noxious stimuli, falls back asleep if not continuously stimulated. And because most mental processes that occur in the brain, the biology of consciousness also called arousal. Coming to the Glasgow Coma scale, so here the least score is 3 and the high score is 7, and if the patient has the score of less than 7 indicates it's an altered level of consciousness. First, eye-opening spontaneous response will give score 4, and to speech 3, to pain 2, and no response 1. And the motor response, obeys command 6 score, and localizer stimulus 5, flexors withdrawal 4, and flexors weak, that is 3, extension 2, and no response 1. And for burst, verbal response, orientation 5, and confused conversation 4, inappropriate words 3, incomprehensible sound 2, and no response 1. So over the score 15, and the least score is 3, altered level of consciousness, the score will be less than 7. Mini mental state examination. So here we are supposed to ask questions. So for orientation, the score maximum score is 5. So the orientation we will ask about the past, present, what is the year, season, date, day of the week, month, and where exactly the patient, which country he belongs, town, city, hospital. And the registration, the maximum score 3. So we can examine 3 unrelated objects clearly and slowly, then ask the patient to name all 3 of them, and based on the patient response we can give the score. And the attentional calculation, the maximum score is 5, and so you can make the patient to count back from 100 to backwards, or even the alphabet from Z to backwards. And the recall for three earlier whatever it's happened in the past too. We can show the patient two simple objects such as wristwatch and a pencil, and we can ask them to name it. And for even we can ask the patient to repeat the phrase. And for nurse, you can ask the patient to take a paper in the right hand, fold it off, and ask him to put it on the. We can put it on the floor, and the examiner gives the patient a piece of blank paper. And in order to assess the language and phrases, the written instruction we can give and make up the patient to write a sentence about anything, any noun or verb, or we can ask the person to copy the picture, a blank piece of paper, and we can ask the person to draw a symbol or picture or something. And attentiveness, patient is certainly if able to attend to you and the examination without getting easily distracted. So here you can assess the level of attention. And even you can ask the patient to spell word backwards or count the months of year backward. And to check the orientation, ask the patient's full name, location, and full date, and the patient is oriented if all three are entirely correct. And if not oriented, write out the patient's response so that the patient is oriented towards the date, time, and place. Speech and language. So, speech, we should assess the listening capacity and the fluency, comprehension, repetition, name, reading, and writing. And in memory, registration, immediate call, that is past memory, present memory, recent memory, and remote memory. Then high intellectual function assess the general knowledge in abstract, the way of judgment, insight, and reasoning. And the pupillary response. And always check the pupil size in the lighted room and reactivity to light in a darkened room. So the pupil constrict or pupil reacting in the bright room and the dim light room. Anisocoria. So the anisocoria is nothing but an unequal pupil size can be a sign of serious brain injury. Pupil reaction and cerebral compression. And in right, A is normal for both right and left, and B in right is a short and often missed, and left pupil is constricted slightly. And in C, that right pupil it constricted slightly reactive, and in left normal size and unreactive. And in D, right normal size unreactive, and in left it's a fixed dilator, and E, right it's fixed dilated and left it's fixed dilated. And you know that fixed dilated is patient probably there. It's we are declaration is one of the declaration that we are declaring that the patient is dead. That is, the people will be fixed. And the language, both receptive and expressive. Cranial examination, that articles needed, the tongue pressure, flashlight, sugar, and salt samples, watch, cotton tip swab, smell and chart, ophthalmoscope, sample of familiar odors and tuning fork. Then otoscope, tape measure, books for reading, book and pen for writing. Then cranial nerve examination. So the first one is olfactory. Olfactory is a sense of smell, and here we will ask the patient to identify any aromatic odor, and if the client can perceive smell, and we will consider the nerve function is normal. And the name, that is anosmia, is inability to smell that a person, that is mainly that the patient does not have any basal skull fracture or an olfactory skull tumor. And the second one is optic nerve. It's a sensory vision, and here the physical inspection of the eye for any pathological change. And we will test the visual acuity, visual field, and fundus. And if there is any deficit, it indicates that there is any problem of eyes, brain, or any nerve pathway. And the third one is oculomotor. Oculomotor, here we will test the pupillary reaction and ability to open and close the eyelids, and we will check the pupil size, shape, reaction, and accommodation. Check eye movement and for pupil equal and round, regular in size, react to light and accommodation. And the fourth is the trochlear test for nystagmus, involuntary eye movement, and the fifth is the trigeminal. Here we will see the mixed sensation to nasal, facial, oral mucosa, and the mastication, the motor division, any innervates, the muscles of mastication. While assessment test, we will ask the client to move jaw, upper and close mouth widely and against the resistance. And the sensory division meditates all sensations to even at the face, scalp, cornea, oral and nasal cavities with the eye closed. And we should check for sensation like light touch pain on the face and eyelids. The eighth actually is a vestibulocochlear nerve. Here we will be checked for sensory hearing and we will do the hearing test. And the ninth is glossopharyngeal. Here we will check the pharyngeal movement and the swallowing, sensory sense of taste or posterior one third of the tongue. So here we can ask the patient to even cough and speak and vocalize different sounds. And the 10th is vagus nerve, test for swallowing and speaking. And 11th is accessory nerve, and the movement of shoulder muscles, elevate the shoulder without resistance, turn the head to both sides, resist attempts to pull chin back towards midline. And the 12th one is hypoglossal nerve. Here we will check the movement of tongue, strength of tongue, ask the client to open the mouth and move the tongue in different directions. And you can see the olfactory sense of smell. Then optic, that is the inspection of the eye pathway change and the visual acuity. This 1 meter away, we will make the person to stand and we have to check the visual acuity. Pupillary reaction to light, whether the pupil constrictor or reacting. And oculomotor nerve, the pupillary reaction, ability to open and close the eyelid. 6 cardinal movements, and here only we will check the cola. Trigeminal nerve, sensation of sensation, nasal, facial, oral, mucosal, and mastication. And the facial nerve. So here we will check the sensation of taste and ask the patient to smile, frown, raise the eyebrow. And the acoustic sensory hearing test we are supposed to do. And this is the cochlear. Here we will do the Rennie test and the Weber test. So the Rennie test, we will keep the uh, tuning fork on the forehead and whether the person is hearing the sound equally in the both ear. And the verbal test, we will give the tuning fork on the mastoid bone. We should check both conductive hearing loss and sensory neural hearing loss. And hypoglossal movement of tongue, strength of tongue. And the motor function testing tone, that is degree of strength, whether it's normal, weakens or moves against gravity. The highest score is 5, and if there is no movement, 0 score. And this is the test of muscle strength, and that is abduction, first one. Second, elbow extension, elbow flexion, wrist extension, finger extension, and the finger flexion, finger abduction, and thumb abduction. And it's a hip flexion against knee extension, hip extension, knee flexion, angle dorsiflexion, and plantar flexion. And this is the manual muscle strength grading chart. The maximum score is 5 and the least score is 0. And the maximum, that is 100%, we will do for there is a complete range of motion against gravity with a full resistance. And the score 4 for complete range of motion against gravity with some resistance. And grade 3 for complete range of motion against gravity with no resistance. And grade 2 for complete range of motion with gravity eliminated. And grade 1 evidence of slight contractility with no evidence of joint motion, and 0 no evidence of muscle contractility. Next, cerebellar function. Here we will test for coordination, finger to nose test, and testing the coordination, the heel test. And the reflexors, testing the deep reflexors, biceps, triceps, supinator reflex, knee reflex, plantar response, and angle reflex. It's the biceps reflex. So the biceps reflex actually the partially flex the client's arm at the elbow and the rest of the forearm over the thighs. Placing the palm of the hand down, place the thumb of your non-dominant hand horizontally over the biceps tendon. And here you have to deliver a blow downward thrust with a percussion hammer on the thumb. And the triceps, flex the client's arm at the elbow and support it in the palm of your non-dominant hand. Palpate the triceps, center about 2 to 5 centimeters. Brachioradialis, rest the client's forearm in a relaxed position externally rotated on a firm surface. Then Achilles tendon, here the client is sitting in the same position for patellar reflex, slightly dorsally flex the client's angle by supporting the ball of the foot lightly in the hand. Movements reflex. First, we have to position the subject. Relaxed hand ensuring dorsiflexion of the wrist and partial flexion of the fingers, and hold the subject's partially extended middle finger between your index and the middle finger, ensuring you stabilize the proximal joint. And next you have to perform a sharp and forceful flick of your thumb and making contact with the nail of the subject's middle finger. And further, the subject's finger will flex immediately, followed by relaxation. And the presence of Hoffman's sign is characterized by flexion and adduction of the thumb and flexion of the index finger. Babinski reflex, and this is the superficial reflex, and we have to test the plantar response by scraping an object across the roll of the foot, beginning from the heel and moving forward the small toe and then acting medially toward the big toe. And the normal response is the downward contraction of the toes, as you can see in the diagram. And if you have any questions, just leave it in the comment box.